On-the-scene video coverage of AHA 2012 is supported by Pradaxa.
It was a design trial to look at tachycardia detection and ways of reducing the number of inappropriate anti-tachycardia pacing therapies and shock therapies.
They changed the way the device was programmed, conventional programming, and then two other forms of programming at high rate cutoff and a long duration of detection before device therapy is delivered, and compared those three groups.
The study was very interesting in the sense that, number one, the number of inappropriate therapies, that is, misfirings of the ICDs, was substantially reduced using both the heart rate threshold change and the time delay change. The most surprising and I think very impressive part of the study was that the mortality rates actually went down when there was fewer ICD firings, and I think that's a very surprising and very useful piece of information.
The study itself was actually reasonably well designed. One of the limitations is that in many cases for primary prevention now, practitioners are already setting these devices up to be at a high rate cutoff, recognizing that if the patient doesn't have a primary arrhythmia, that programming a low rate cutoff is more likely to induce a therapy for an inappropriate tachycardia SVT than an appropriate tachycardia. So I think that's one of the limitations for sure.
We should carefully consider how we program these devices. The responsibility lies with the physician to choose wisely, to choose how they're going to program these devices.
I think if you're a non-cardiologist and you have patients with implanted ICDs, particularly for primary prevention, that could be a patient with an ICD for a sudden death episode or IHSS or end-stage heart failure, for example. I think they should send that patient back to the electrophysiologist with a review of thresholds, a review of the number of times this is fired inappropriately, and presumably adjustments of those thresholds to improve outcome.